The patient is a 72-year-old pensioner who lives nearby my practice. He is allergic to aspirin, has had a mitral heart prolapse 10 years ago, and had myocardial infarction 3 years ago. The patient is on a list of heart medication including warfarin with an INR of 2.5 to 2.6. He is hypertensive, however, is controlled by medication. The patient's relative physical health is frail and has a low heart rate of 50 beats per minute below. He would like to improve chewing foods with the least invasive treatment options in dentistry. The 3/7 was extracted last year at another practice. It was very stressful to the patient and he had an anginal episode after the extraction. He had a lower plastic denture issued some time ago. However, he highly disliked it and threw it away 6 months after it was issued. The other concern also included the concern of his posterior fillings that keep on falling out. On examination, the patient is of a class 2 profile with satisfactory range of jaw movements. His upper arch is currently undergoing restorative works and has a satisfactory oral hygiene with a BPE of 2. The patient is partially dentate and wears an upper chrome cobalt denture, which he finds it very comfortable for over 10 years. The teeth 4, 6, 1, 2, and 2, 2 have been root treated, and some of the posterior teeth, especially the lower molars, have been heavily restored. The patient has a decent motor control and is able to maintain his own current denture. The 1/7 is over-erupted but does not pose any occlusal interference. The patient is happy with his current vertical dimension and his maxillomandibular relationship, and he does not want to have it changed. Patient has a satisfactory salivary flow rate. The diagnosis pertaining to this case is a partially edentulous upper and lower arch with heavily restored teeth. Discussion of treatment options are listed in the clinical write-up. The definitive comprehensive treatment plan would take into account the patient's wish to chew and masticate his foods, where the majority of his lower teeth were not adequately restored. First, we go through with the protocols of caries control and oral hygiene instructions, and then followed by, in this case, the fabrication of lower crowns of his 4, 6, and 3/7, which is consistent with the protocols of crown preparation. The 4, 6, and the 3/7 will then behave as abutment teeth with adequate rest seats and embrasures for the future lower removable partial denture. It is then the metal frame lower partial denture will be made utilizing the 4, 6, and 3/7s as precision abutments. Clinical outcome of the case. The 3/7 is no longer sensitive to cold as it used to be after the crown has been issued. There has been adequate cuspal protection on both lower molars, and the restorations no longer feel sharp and does not cut the tongue, and the patient does not need frequent visits for frequent fillings. The lower teeth are easier to clean and maintain, and once the future removable partial denture has been issued, there has been a much easier fitting, and the fit is more snug and comfortable and smoother. The patient reports a significant increase of confidence in chewing harder foods, especially on the left side. A periodic review of 1 week, 2 weeks, 1 month, 3 months, followed by biannual visits is necessary to review and monitor the patient's coping mechanisms, and oral hygiene. Oral hygiene instruction is constantly given and motivated